Thank you. Let's start like this. Uh, See, as for that video, I was like that, uh, but things changed. In Australia, when 10 years ago, uh, we had to take some exam called as OCI. OCI is an exam where you would see a patient independent without knowing anything, including the name, in another state, and two consultants who absolutely know nothing about the patient would come and sit and watch how I do the interview. And I had my exit exam in Thomas Emling Hospital, which is quite similar to Park for criminally insane. And as a preparation for that exam, I needed to read, of course, about psychosis and antisocial personality. But I think to pass the exam, that's only a superficial issue that we needed to read, but also we needed to demonstrate so many variety of thinking processes that goes in it, in the sense that we could differentiate psychosis that is hidden from psychosis that is feigned, and antisocial personality who is denying any risk factors or minimizing it, and also able to manage the counter transference, which could weigh from a sense of fear because of the intimidating behavior these people can show, to being colluding with them because of the superficial charm that they may have, and also deep disgust that you may come across when you're handling this group of people. So in that sense, I started watching a lot of movies and reading novels, and I came across one of the CIA profiling documentary about serial killers, and that's how I kind of came and I passed the exam. So, and once I became a consultant, my area of interest has been studying the technology companies, the big data, and how they use the variety of data, and it is about how they, uh, so that they use how they could predict our behavior, how they understand our behavior, and how they influence our behavior is my area of interest. But this particular presentation has been precipitated in a way in the context that I was involved in a kind of a vigorous discussion with some of my colleagues about the role of symptoms and role of a person's life experience. And I said, and I won't teach my medical students about psychiatric symptomatology. I generally push them to understand the person's reality. And this is based on my premises that by taking an approach of symptoms, we are kind of reinforcing without consciously meaning the victimhood, the defectiveness, and disability. And by trying to normalize the person's suffering, we are also at a great potential to look at the strengths the person has, the resilience, the variety of coping mechanisms that they have used, and also foster sense of ownership that is very, very important in a long-term treatment. So that's the kind. So based on this, I have prepared this slide. To go back to myself, coming from India, I studied medication first, like antipsychotic medications first, and then learned about illness like schizophrenia and depression later on in my medical training. And when I did study those medical illnesses and so forth, my initially I gave, of all the four noble truths, I gave a huge importance to the symptoms. So if the person has symptoms of depression, they have depression. If they have symptoms of mania, they have those kind of things, and it helped. And this kind of drove my history taking, and so those theoretical constructs help me to take a history, make a diagnosis, or make a treatment, and those sort. But coming to Australia, I kind of has to come up with a slightly different paradigm where we have to look at triple P way of formulating a case. So that, in a way, changed my attitude in towards the history, the treatment, and the diagnosis. and how they are linked to the our management plan at different stages of it. So with this, I passed my exam, and as a senior registrar and a junior consultant, kind of what I started seeing is, even though the people come with a one crisis and for which we started the things, they go through variety of crises, and we give variety of labels to those crises, and we manage those crises in different sense. Like once the person became withdrawn and anxious, we just say that he's not engaging with us and we'll discharge from case management and so forth. So I think then as became more as a senior consultant, I think I started becoming more and more involved in the what we call as a long-term management of uh, our patients. And in that domain, what I even despite uh, providing a pretty good longitudinal follow-up and pretty good stability when we discharge, they still would come back after with relapse, and we would not know how it would happen. So in that area, I think I was reading about variety of people, and of which he attracted, Adolf Mayer attracted my attention. His view is he would not see mental illness as a biological illness or a brain pathology. Brain pathology would not indicate the psychiatric illness, but it is a reaction, a dysfunctional person reacting to his environment. And he suggested that we need to take a great detailed approach to the person's history, which focusing on not only social biological factors which affect entire period of his life, and only when we consider those factors in our diagnosis and its treatment, we can provide a better management plan. So he has sense, and I think as I took a detailed history, what I started realizing is we are only looking at the very very surface issue of in the sense of psychosis or whatever the crisis is, only small ebbs and flows of this person, and they have a huge problem, and almost that problem we can say it is built into the person's personhood or self, as he was saying. And in those kind of things, it had a huge kind of it raises several ethical dilemmas. How much control that I can have, how I would collaborate, and so forth. This pushed me into philosophical discussion of what constitute as a mental illness, and what how to understand a personhood, self-identity, and so forth. And obviously, this at some level appeared quite a different kind of paradigms to understand. So in this context, I started reflecting on it. And if we have to understand a person's self, the approach to understanding if it in so many ways are quite similar to how I possibly may need to understand the symptoms, how it came to existence at different stages of his life, how it was maintained, and things, and how it was interacted with it. And at the same time, if we have to understand the person, we have to see it in the context of his family life or important people in his life. So those, uh, in the same way, the symptoms or the diagnosis also run from one generation to another. So there is a huge kind of a overlap. So to me, from a clinical point of view, it was good. And another dilemma that also has to overcome was when we are trying to understand another human being as a person, uh, we can never understand a person as he is. We'll always uh, see him through the lenses that we carry, with the bias that we have through our personality. So the same person could be seen by differently by different people. Uh, so in that sense, so we also need to be aware of ourselves. In that sense, I needed to do a little bit of digging on myself. What I can say publicly is that I was trained in quite a biologically oriented medical training, which is based on a scientific understanding and so forth. And my medical training was more biologically based, anatomy, physiology, biochemistry, and that's how it's built. And psychiatry was a tip of the iceberg of the last 3 years of my training that I did. So that's what our no, uh, training was. And with this kind of training, in retrospect, I feel that possibly I was more like uh, Doc Martin in my bedside manners and interaction style and the diagnosis and so forth, which worked beautifully in India, but it did not work much in Australia. When I came to Australia, I initially felt it's an utopian society. I did not know this documentary or teleseries. I felt that there's a huge amount of resources. We can document it. We can discuss with so many people. We can come up with variety of perspective and so forth. But as I got more involved in the management, I started realizing all the drama that were carried out in the name of KPI, risk management, quality improvement, and so forth. So but as an immigrant doctor, I always know many of the. I went back to India. I've been going back to India almost um, every 9 months. I spend nearly a month in India, and when I go to India and I reflect on my personal life, my professional life, and so forth, and this is the kind of a despair that uh, I go through. And based on this, kind of I try to come up with some kind of a mediocre understanding of how this understanding of self and understanding of psychiatric illness kind of makes sense, how they overlap and so forth, and how we could use it in the recovery framework in a chronic disease management model, how we could empower patients and so forth. But coming to the what we do on a day-to-day basis, we take a history of symptoms, symptomatology. That's the predominant things. And when I reflect on it, no, I mean, as a medical graduate, I had a huge belief that medical symptoms were the true reality, and it's the social work job is for those uh, people who were unable to get into science. And psychological symptoms were kind of reaction to that. I could not really see them as an independent illness. But once I became a psychiatrist, I kind of changed my mind and said that psychiatric symptoms are as real as medical illnesses. We should not stigmatize them. But these are all social problems. That's not doctor's problem. No, no, no. That's something. But as I became a consultant, I think my review is there is there's no difference between these three categorization. All these three categorization could be seen in the same biological symptoms, social problems, and psychological problems could all be seen in the same domain using the same kind of examination. Like you can take any of this symptomatology and the problems that comes with it, and you ask the same kind of a questions by just replacing the what we consider to to gain a better understanding. So in this sense, as I was able to know come up with both understanding, especially in a psychiatric setup. It helped me hugely in the sense of understanding the self and the disease and so forth. So based on this, I've been thinking about profile and what socio-demographic profile should do. I think in order for me to teach a junior doctors or teach myself, I think the profile should fundamentally should give a structure, and it should give some kind of a categories. And based on then once I have those one some kind of an item, then I can decide normal or abnormal. So this is a basic structure, and we can come across human beings of all variety, Then we can decide what is normal and what is abnormal, and how do you differentiate, what is abnormal and what is normal. Okay, so these are the uh, 8 pigeonhole items that I would consider as a part of profile. And this pigeonhole categorization is quite helpful, and it gives a simple schema. It helps people to communicate quite easily. They're much easier to study. And once we understand, it kind of helps us to build a, build a holistic picture of a person from at least from psychiatric perspective. But at the same time, when we give this, the more important is not just studying those categories per se, that is more important, but what we need to help the medical student, junior doctor, is that you are have to see that in the context. See that in the context. So yeah, if you just directly go on trying to attack, you are kind of you will be you will get stuck, and so you have to take a step back and see the context of when this is happening. The way I would go ahead would be heavy emphasis on mental status examination, and mental status examination almost should start as soon as you see the patient, and possibly it should have finished before you start talking to the patient, and that should give a lot of clues. And I find that uh, humanities, the artists, comedians, gives much better tools and description of a human being. What for a psychiatrist, what we call as mental status, they describe it much more vividly, and I learned more from them. So, what through this mental status and through the process of history taking, what we really study is the lens with which uh, we study. So a person who is sad or depressed would see the life in a bleak way. So even though we are asking the question, it is a two-layered approach where we are seeing the color with our, if they're happy, manic, disinhibited, they have a change. And if they're quite paranoid, they try to hold on to the personal information as if it's a highly secret. I'm not going to tell my name. You don't need to ask a lot of symptoms of delusion of persecution when a person is so paranoid as not to give his name. So those are all the kind of clues that I try to teach. And also, one of the fundamental belief that implicitly carried by junior doctors is the patient is there, they are cooperative, they want our help. Now, they would collaborate with us. No, that's not how it works. They they are almost trying to attack us. Sometimes it's going like going to a war, and we can have a dangerous uh, wound, dangerous injury because of them. They could be quite racist. I've been in emergency department. I've been abused several times. Or they may express their frustration with the system on one person whom they feel safe to express. Or they may use Australian slangs, and I used to say that they are bizarre delusions with olfactory hallucinations, or they absolutely have no insight and they just want to go, or they're quite passive aggressive, or uh, in variety of forms, or sometimes there could be huge secondary gains, or they could be idealizing you, initially. All those things, so all those factors also need to be uh, considered and managed before we go and collect the things. And this is a process related skills, and that comes into picture quite early on, within 1 minute of our interaction with the patient, and the patient does the mental status and makes a decision how capable this particular doctor is before the doctor makes any diagnosis. And going further, another aspect of the process of interview is the process of interview is also about the thinking that the doctors have to show. They don't just listen to what is spoken, what is presented, but also they look at what is how it is presented, and also what are the things that are not presented, well, and how whatever that is not presented was hidden, why it was avoided, how it was missed, how both of us contributed, and those kind of a reflective thinking is there. And from a psychodynamic point of view, it is this is the fundamental aspect on how we would help person to speak an unspeakable truth of their life. But however, that has to be done in a subtle way that in a way the patient doesn't feel that we are examining them. Uh, so that would lose the rapport. Uh, Coming to the active listening or reflective listening is very very important, and the issue of emphasizing with the person's current subjective experiences within the in this interview without going back to the objective data from the past history outside this interview context is important, and that could only be obtained once we are able to subject to experiences are validated. And Carl Roger kind of gives variety of techniques for that. Now, even before mental status come into uh, play, we also have to be mindful that content of the interview is also driven by the context of the interview. Context of the interview drives mm, uh, when it is happening on a Friday night or in emergency department or in HTU, Damel ward or a fountain house, all those things makes. So the person has to have a thinking hat and kind of a mindful awareness of the situation is there, and it demands decision making uh, at a micro level has to be things. And I think there is a huge emphasis that uh, video based like video recording of this like with uh, any kind of psychiatric interview, and uh, having a supervisor watch those video and help them to refine it would be one of the way of improving people. But I think we'll not go there. But I think just now looking into the profile, uh, as I said, these are the eight things, and in the past it was quite easy for us to say that there are two genders. That was quite easy, and nowadays I think we need to be much more open-minded and so forth, and also need to be open-minded from the very beginning. Coming from a different culture, it was not an easy aspect for myself to say that person who is going for a transgender change, how would you have a unconditional positive regard? It's quite a difficult task. And then the age of the person, which kind of strikes out. It's even the profile. It is part of the mental status examination, and it already gives you where do they picture, and that again depends upon our theoretical understanding that we have about human life. And I generally encourage all my medical students to read at least Erickson. Is among all the people, I think I find that him to be much easier to understand, much easier to use in a clinical situation. And other is race. Again, we can easily, we don't have to ask. Those are the kind of easily we can make it out much easier. And within that rises several line of questioning, which can be brought bit later, a bit earlier, depending upon the context of the interview, and that gives a clues of exploration of a variety of things that could be explored. But however, what I felt is the kind of a stereotype is that I myself carried towards Australians as they being dumb, drunk, racist, kind of a stereotype that I had, and I needed to overcome. That took a bit of a time. Now, coming to the name, and name is there, and the labels in our marquee exam we did not know, but in clinical exam we have the names. But however, we don't really give lot of weightage, even and we don't use the name as the interview go along. And if a junior doctor just makes a small change in using of the person's name during the interview instead of just asking the question as if he's an object for study, that improves the rapport significantly. And obviously, there are a lot of other psychopathology we could use in the terms of meaning of the name and how it came to be there, and if it was changed, and the reasoning for change, and so forth. After this, all these things almost are easily available, and as soon as this is obtained, most of our junior doctors kind of jump into asking about the presenting complaints. Tell me how you came to be here, how we can be of some help. Okay, this is quite a medical training based, and it also comes with a presumption that the person knows what the problem is, person wants help, and we are capable of providing that help. I don't know whether all those things are true in all cases that we see. Uh, that's and it kind of carries on to the even when the people present the case to another to a consultant, that carries on. They say, "Oh, Mr. Joe, chronic schizophrenia." They already told the diagnosis, and they already okay, nothing more. Uh, I would suggest that people should refrain from this approach and use conversational style, which is a fundamental aspect of what we call as a supportive psychotherapy, which is rock, no, on which building a rapport is one of the more important aspect, and profile gives a clue for a normalities of a person's life. I would use house as one of the easy, non-threatening kind of a situation. It kind of gives a foot in the door kind of a experience into the person's life, where you can gently ask, where do you live? After discharge, you can go back there. And depending upon what you find in the context, you can ask, how big is the house? Where is it located? And so forth. Obviously, they are not cookbook answers, but they have to be changed depending upon the context. Another is a job that's also quite a easier to ask. You can always ask, how you know, uh, what do you do for living, which is generally non-threatening, even though we kind of lot of times assume that this group of people are on a disability support pension, not working, and so forth. But it kind of gives a clue. But I think just not about just job, but I think in this arena, I would like to explore how the person spends his time. So, in the name of you uh, asking them to describe their typical day from the time that they get out of the bed till they go to bed in the night, and going through things in a systematic manner, that gives a huge clue about their symptoms, their functioning level, the kind of risk or perpetuating factors, and so forth. I mean, if there is a eating disorder, include eating habits there. If there is a manic patient, you already got the things. If the person, so forth. If there is a negative symptoms, you can make it out. You don't need to host the symptoms. That is they. Obviously, it also gives a clue about the educational level. So, is the intellectual capacity or the financial situations, and it also kind of you can use hobbies and interests. The person has as another avenue to enhance our therapeutic rapport. Uh, as one of the area of exploration to know them as a person. And in the same domain, I always say that as we explore the realities of this person in the name, we also have to explore in this era, virtual reality, this person is involved. It is highly important, I would believe, and it drives a lot of risk factors. Now, this is, I would say, this is the most dangerous aspect of profile, which lot of junior doctors struggle in the sense that asking about a person's relationship, intimate partners, family life is quite a discomforting. Okay, as a physician, we don't have a huge discomfort in looking at different parts of human body as an objective person, and the patient also kind of cooperates. But exploring this aspect, both the doctor feels sometimes hesitant, and the patient also asks the question, "Why do you want to know? This is nothing to do with. I don't want to talk about my family. The family is not there." That's the the managing to get the detailed account of the person's relationships is something. And also some of my patients, they don't have a normal relationships. A lot of their relationships are quite inappropriate. Sometimes they are awkward. They may not those relationship also gives away a lot of clues about the nature of the person's life difficulties. I've done family tree presentation recently. I suppose I encourage people to do, and also I ask my medical student to read bit about the human relationships and the stages of human relationships and so forth. It helps to understand and build better questions. Linking to the variety of services, starting from the GP to variety of other services, we can go on. But the point is not the content. The content is how we helping the person to develop a organic interview process. Is very, very important. And obviously, this is has to be tailored at different level. And there are so many issues that could be covered, and we always say that we have limited time. The patient want to talk about so many things, and there are so many areas things. So time has to be managed. Time is a resource, and what is wanted, what is needed are entirely different things, and that has to be there. And also it needs some kind of a limit setting, reality testing involves in the sense that sometimes even though the person is crying and all those things, we may have to set limit. We have limited time today, and we have to move on and so forth. That so teaching this is not an easy task. Teaching this is not an easy task. Me and Mani had several conversation about these things. I think when Fawaz went to CLP, I think she had a tough talk, and I had to defend my position with her. And those are the kind of common problems that we identify, common barriers that we identify. There, junior doctors are too young, they don't have experience in life, and it provokes a lot of emotions, and they don't know how to manage it in their own life. How would they manage in this interview, and they just want to pass the exams, and they want to just to see an classic case and so forth. Or sometimes underneath all these things, the one of the fundamental thing is, God's sake, they're doctors, they're not social workers. Why do you want to do this? That's one. And another thing that I also say is, come on, it's just a case, man, get over it. Now, how much can we know about each person? That's also there. Okay. Sometimes I also wonder, that's also compassion fatigue. But I find that if we give a reason why this is important, generally people find it easy to do it. Obviously, and just to go through, I think this movies also influenced my thinking. This readings influenced it, and recent changes in the healthcare sector, digitalization, the patient empowerment at different levels, and has pushed psychiatry to humanizing psychiatry because we are mechanical in our practice. But irrespective of all those things, I think I would strongly suggest people to read uh, 10th edition of Kaplan and Sodak, which is there in the registrar room, and clinical psychiatry, this two textbook. And I would urge people to read initial few chapters before jumping on to studying schizophrenia and biological origin of schizophrenia. They need to read the initial things which are basic first. Only one message I want to convey is that we don't treat illness or diagnosis. We are here to take care of person, whole person. So that's what we would like to do. It's open for discussion. Thank you for your patience and listening to this long talk. Thank you.